champions, KO Show! Are you ready? Tonight, we are going to witness the most anticipated match in the history of professional wrestling for the heavyweight championship of the world. Are you ready?
Thank you once again. And so to start it off, we have two cases from Vahab Seti and Jorge Rocha. And I was just wondering if you could start sharing your case, Jorge. Are you ready?
Wow, it's good to be here. Thank you so much to invite me. This great honor to be with so outstanding colleagues, and let's see if I can share something new for you. Have my disclosure that does not concern this talk, and it's a great honor to share my case with my friend from India, Dr. Seti, very good friend. I don't know why they stopped to. Yeah. This case, a 52-year-old female. She came from my office and said, "Oh, I was seeing something, and I lost my vision. My only eye 8 days ago." She was submitted to vitrectomy for diabetic retinopathy 2 months ago. The visual acuity was count fingers 1 meter, and the pressure was 8. And when I examined the back of the eye, I saw that a huge macular hole and a lot of fibrosis, and I say, what to do? It's not easy. The only eye for diabetic patients who are 52 years old, very young woman, and I have to do something. And I say, I will try. And then this is the OCT. You can see that this hole is more than 3,000 microns, and we have a big retina detachment, macular detachment. And then I start to operate, very careful, try to feel all the membranes, very careful, try not to harm more. And when I finished to peel everything, I said, what I can do for this macular hole? I said, maybe I can do an autologous transplant. And I just cut some nasal retina and just put inside the hole, very careful. That moment I just turn off the infusion, make less flow, and I just make the air fluid exchange and put oil and laser all the peripheral rows. And then this patient, after the surgery, have the graft here very well positioned. And with 1 month, she got 20/80, and after 1 year, she got 20/70 visual acuity. And then just invite you to meet each other face to face in Fort Lauderdale, May 8 to 11. Thank you.
What a case! What a case! And the patient
I
got
can't hear you. Put some. It's close your microphone.
very good case, George.
Nothing. No sound. Oh, now go.
Can you hear now?
Perfect. Yeah, perfect.
Yeah, very great case. And the patient's got 2070. It's a large hole. And did you have any difficulty from where you did the retinotomy on the other side into transferring the patch to the actual macular hole? Did you use? Did you rely on perfluorocarbon liquid, or do you think that was not so important?
It's important. PFO I use a lot when I do autologous transplant, but in this case specifically, I was afraid. Why? I have a huge hole with a lot of retina detachment, and I say, wow, if I put this silicone perfluorocarbon, and when I'm gonna took it over, it's so big hole that's maybe gonna be some depth underneath the retina, and I could not move this. And I say, okay, I'm gonna turn off the infusion completely and work because you are using the trocar, valve trocar, we are in a closed system. And then I said, I'm gonna work all with the no fluid, and then I have very slow movements in the vitreous cavity, and I did, and I could put the patch, and it could make the air fluid exchange very slow. I think that I took more than 15 minutes to finish the air fluid exchange because I don't want to make a lot of movement inside the vitreous cavity. The intention was not to dislodge the retina graft. To take the graft was not hard because I have the retina detached in all this portion of the eye, and then I just make measure the size of the hole, and then I just cut and drag very careful with a forceps. It's not easy because you may flip the retina. You're gonna don't know what's the upside down position. What's this photoreceptor? What's this internal limitation membrane? But what's good.
Yeah, that's amazing. My concerns would be that, of course, with 23 and 25, and you to have a valved system, so that means that no fluid would get out. So this is a good scenario. But in case you had a small hemorrhage, for example, so would you have to turn on the infusion line a bit in order to avoid this bleeding? Or do you think you wouldn't have this bleeding occur?
You mean if because it's diabetic and then maybe you're gonna have some bleeding? I just make a very good cauterization in the retina before cut the retina, and may have some bleeding, but I was lucky, no bleed at all, and then I could turn off the infusion because if you have some bleeding, you may need some pressurized eye to try to stop the bleeding, but was not the case. I agree that sometimes you have to do many different maneuvers to get very good graft in the hole. You have to put the perfluorocarbon, to use the bimanual technique because it's more safe to stable the patch and not to flip it over. But in this case, I was trying to be very simple and words.
Yeah, it worked well. Marcelo, would you like to comment?
Yes, okay. In this macular hole, big macular holes, I tried to put in the last 2 years platelets, and it works really, really well, using obviously an activator. And I presented that case in Chile, I believe, and with good results. I mean, these big holes, we need to do everything we can to close it. So, have you ever, Jorge, used platelets in your holes?
No, I don't have any experience doing platelets in the hole. I use when I have a huge hole, like more than 1,000 microns. Nowadays, I'm using the autologous transplant, and then that's work well. I really don't know if we the photoreceptor from the graft we're gonna populate and works in vision. We don't know, but I believe that's just because you put some cover in the hole, this big hole, you can get at least a tamponation for the retina detachment. If you saw at the beginning, I had a huge macular retina detachment. If I solve this problem, the patient gonna get some vision. It was my intention, and I really don't know if really when they transplant retina and this new position of the retina, this piece of retina and piece of photoreceptor wanna survive and works like used to be. But for at least, for example, you can use many other things to cover the hole. But when you have huge thing like this, I think retina transplants is a good option.
Very nice
you.
presented. Thanks, Georgie. And your partner now, Dr. Vaibhav Sethi. Vaibhav, are you ready?
Yes, I'm ready to give him a fight. But it was a very challenging case. I really enjoyed the way he tackled the huge macular hole. It was not even a large macular hole. I don't know what you call it. Triple XL macular hole, but I think it was very good planning.
Gigantic macular hole, gigantic.
Yeah, it was really big. And I think, very well planned. So I'll just share my case.
Sure.
This is also an interesting case. Yes. So I'll just directly jump to the video. So this case also is it's an unusual presentation of an ERM. So this case came to me a week. I operated a week back. You'll see. So this fractional ERM and there's an extensive schisis. You can see this. It looks fine, but you can see the extensive schisis that is there over the ERM. So this is causing traction. So what I did was I started with a tricot-assisted vitrectomy. When I started vitrectomy, I tried to induce PVD as we normally do. But what you'll see in this video is there is a normally strong attachment of the posterior hyaloid to the retina. You could make out. So when I was doing this vitrectomy, you can see the different islands of posterior hyaloid. I'm trying to pull with maximum vacuum, but it's taking me a lot of time to clear off this posterior hyaloid from the macular area. And from the other area, if you see closely on the mid periphery, the posterior hyaloid is very schitic. So you can look at this. You see this. So this schisis is there, and there's also attachment of this posterior hyaloid to the epiretinal membrane, which I just trimmed off. Because of the attachment, there was a small retinal hemorrhage that happened while I trimmed off that schisis tissue. So till only after the mid periphery, after staining it with BBG under air, this is the picture. So this was a extensive schisis, and you can see. So what the plan here initially was that maybe I'll create large flaps of ILM and just leave it over the fovea so that I don't create much traction. But when I was continuing my ILM peeling, I realized that the hole was very extensive. There was a very tough membrane. This ERM was really adherent. So even without it causing any retinal tissue touch, there were multiple hemorrhages that happened because of the adherence of the ERM over the macula all across. So the thing here was I took my time and I peeled off the ILM all across the foveal first area, so I go centripetally and avoid any traction over the fovea. But you can see here, even with multiple attempts, it's very adherent and taught to pull off this tissue. Finally, I realized that this removing the ERM totally would be the solution for this case. So I went ahead and completely removed the ERM, and the ILM also came along with it. So this was the tissue at the end that I was able to remove off, and finally I finished the peripheral vitrectomy and checked everywhere like normally do 360 degree, checked trocar entries, everything was fine, and I left this patient under air. So I did a fluid exchange, tried to place in air a week post-op, and you will see the OCT that I took a few days back, and this is how the patient is now. So he's improved. The vision was initially 20/80 and now it is 20/40. But you can see that the extensive schisis, the ERM, the tractional component has been removed. And fortunately, this impending thin tissue of the hole did not form. So, the only the dilemma I had while doing the surgery was, should I have just left flaps over the fovea like we do an ILM peeling? Or like I was lucky, maybe just remove it in total, like ERM. So this caused the traction went away and I had a better result. So I'll be observing this patient. Yes, thank you.
Great case, Vibhav. And the ILM was pretty tough. It was difficult to remove it, but when you got the ILM the second or third time, you remove it all over. So there was a little bit of a traction over there for maybe some time. Jorge Rocha, how do you discuss these cases?
Dr. Senti, thank you so much to present so beautiful case. I have first one question. This patient was a high myopia or not? Because when I see the back of the eye, it doesn't look like a very high myopia. But when you show us the OCT, looks like macular schisis of high myopia patient.
Yes, I was also surprised with the presentation. Normally, we don't see an ERM with such a presentation. I had shared it with Dr. Barbara as well, taking her inputs, how should I manage this patient? And she herself was a little surprised because this is a little rare presentation of an ERM. So this was a tractional ERM because this was not a high myopia. But you can see, I didn't show you other scans. So there was, as you can see, there was so much extension schisis that happened over the period of time that the central fovea also got split. So there was an impending macular hole. So the main worry was, if I operate this patient now, there could be a chance I can create a macular hole. But the question is, if I don't operate, the macular hole will itself form with natural history.
Yeah, the natural history is going to be an open macular hole, a full thickness macular hole, just because we have traction. And the tract is so strong that make open inside the retinal layers. And then one thing that's we have to very careful is to remove the hyaloid and the interlimitant membrane. Some people use just to macular sparing, try not to push too much, because if you see we have a lead, but the lead is very thin, and then if you move too fast, you're gonna open a hole, and then gonna be a little bit more difficult. And you did correct. You remove a large area of interlimitant membrane to relax the physiopathology of this schisis is probably the traction of the interlimitant membrane combined with posterior hyaloid, anteroposterior and tangential traction that makes this retina to split. in the middle.
Yes.
And then when you remove this, you're gonna relax this, and naturally gonna improve. This improvement is not fast, gonna be more fast the first 3 months, but during the whole year, gonna have improvement and reorganization of the anatomical position of the retina, and maybe this patient gonna have a very good vision, and you saw that a patient with macular hole that's gonna happen, gonna be much more difficult to fix this. But congratulations, very good surgery and beautiful case.
Yes, if you
Congratulations.
saw the video that with the tricor, the posterior hyaloid was so attached that you
Yeah.
can see the splitting. The macular area was attached to the mid equator, mid periphery. So when I was doing retract, I was pulling on the posterior hyaloid there. There was sciatic retina. The macula got pulled also. There was a subtle retinal hemorrhage that happened because there was such a strong attachment of the posterior hyaloid. So you normally see such cases in the pediatric population, but not in an adult, an elderly lady, but so it is rare presentation. Thank you
Probably
very much.
this attachment of the posterior hyaloid in the macular area was the cause of the schizy and macular hole potentially. And then it's good to remove all the internal limiting membrane, but I believe that's when you finish the cleaning, all the posterior hyaloid may solve the problem.
Yeah, really cool. And very beautiful images I have. I love your case. And now to proceed, I would like to invite Olivia Valdivieso and Ahmed Habib. Olivia, are you around? Are you ready?
Hi, Hudson. Thank you. Good morning. Good afternoon. It's my pleasure to be here with you.
Honor is ours, and we are neighbors, country neighbors here. And Bolivia and Marcelo Murilo Sassamoto are in Bolivia, just very close to Brazil. And I'll have a chance to meet you guys as soon as possible. And I know that last year, Marcelo had a very great meeting on the wine. Could you just say a little words on this meeting, Marcelo, for people?
The name is Winetrectomy. We did a retina wine reunion in Tarija, Bolivia, which is the part of Bolivia similar to La Toscana. And we have a really good time with Olivia and 50 retina specialists from all Latin America. So it was a really good experience. Right now, 2025 is in Santa Cruz de Chile, in Chile, our next meeting of Winetrectomy. And
Marcelo,
2025, we believe, is in Mexico. So you are really well invited to this experience with wine and retina.
Marcelo, since I myself I don't drink because I'm a wrestler and a judo player, and so could I participate just in the classes, in the lectures?
Yes, for sure. Yes, no problem.
So we'll be there. And so Olivia, are you ready to share your case?
I am ready. Let me see. Sure. Can you see my screen?
Yes, yes.
Thank you. Okay. So thank you for the kind invitation. It's my pleasure to present here with you. I am Olivia Valdivieso, and I'm going to be with Dr. Habib. This is a rheumatogenic retinal detachment in an active toxoplasmosis retinochoroiditis. This is a 55 years old male that has 1 month of blurred vision. He came with a hand movement, cellular reaction, and a big retinal detachment, as you can see here in the echography. He had, we initiate on dual oral antimicrobial therapy with trimethoprim, sulfamethoxazole, and clindamycin twice a day. After 3 days, we began with oral corticosteroids, and after 7 days, we went to the OR. We did a combined surgery. We did a normal cataract surgery with intraocular lens, and we did a 25 gauge pars plana vitrectomy. As you can see here, it was a key and temporal tear associated with a rhegmatogenous retinal detachment. It was here the active lesion adjacent to an atrophic pigmented old scar. The vitreous was very dense, and here the creamy white initial lesion. We create a PVD. It was very difficult. Patient was 55 years, and here you can see the Heian rhegma. It was from 1 to 5. We clean very careful the borders of the lesion, and we clean very carefully the vitreous base. We went all 360 degrees. Then here it's important to say that this fluid air exchange was very careful. We take a lot of time trying to make the fluid air exchange. Then I apply a 360-degree laser combining with aspirating, and then I apply silicone oil, 5,000 centiliters. This is the end of the first part. This is the OCT after 3 months. The retina was attached with a macular epiretinal membrane. So after 8 months, the patient was clean with no active vitritis or cellular reaction. So we decided to remove the silicone oil and make an ILM peeling. We did a 23 silicone extraction. As you can see, all the retina was attached. Here was the Heian retinal tear. The retina is clean, the scars, and we applied brilliant blue for stain the ILM, and here you can see the ILM peeling. We did a 360-degree peeling. I was very carefully here in this part with the scar, and we did an air fluid exchange. After this is the end of the eye, and after 1 month of the silicone extraction, this is the OCT. The patient went from hands movement to 2080, and that's the end. Thank you for the kind invitation, and I want to invite you to the Bolivian Congress that will be held in November 2025, and for 2026 to Brazil to the Panamericana Retinal Vitreous Congress. Thank you.
Thanks, Olivia. So, welcome to Bolivia, Brazil. These main events are going to be great. And I want to thank you for such a nice case. And we cannot give it up, never. And when you removed silicone oil, and then you did it so beautiful ILM peel, and so not very many people would do that. Some people would just wait and see and do OCT to see how it works. And of course, you minimized complications such as contractions, such as epiretinal tissue after vitrectomies, and so you removed the ILM right away. That was amazing. So I want to congratulate you for insisting on the case. And retinal detachments, they really may end up with complications, later complications, late complications with PVR and whatever related. What do you think about this VibeHab, Seti?
I think it's a very well managed case. The only thing I thing I would have done differently. Maybe I would have, in my case, but put in PFCL, but you managed very well under air. I think you did a great job. And I think the retinal folds also went away after you put in the silicone oil. So that was very good. I think that's something that I as in giant retinal tears, I normally plan to inject PFCL, but I think you've done a very good job under air. Well done. Thank you.
Thank you, babe. Yes, that was a very important point to use or not the perfluorocarbon. Most of my college thinks that they will use it most in these key and retinal tears. I definitely use it when I really need it. I left it for the final movement because I am always afraid that the perfluorocarbon goes inside the retina and complicates more the situation. So when I can not use it, I prefer to not, but it's a good option to use it also.
Okay, Athanasius, what are your thoughts on this beautiful case? Your mic is closed. Let me try open up your mic, please.
Okay, then.
Oh yeah, it's
I
ready now.
think it was a step-by-step beautiful presentation of what we should do. And it's a huge tear. I don't think it's a giant tear. It's just a normal tear, a big one. And the use of perfluorocarbon is always to be cautious about it because you can have complications from perfluorocarbon. And sometimes, if you can attach it without the use of many instruments and without doing a lot of things, is the best thing. The less you're doing in order to attach the retina, the better for the retina. I don't fully agree with the ILM peeling at the end of the operation, of retina attachment, because for the fellows, it's an iatrogenic trauma that they can do at the end of a very successful operation, try to remove the ILM, which is not so easy. And I would hate to have some drop of vision because of manipulation, surgical manipulation of the retina, at the end of such a difficult situation. So I think we don't have a lot of PVR on this case, especially the macular packet and everything. Statistically, in my hands, I don't see the need of every retinal attachment to do the ILM peeling. I think I choose the cases where I do the ILM. That's the only thing that I'm having. But congratulations, it's a beautiful thing happening in Bolivia, and I would love to be there and see the whole country.
Thanks, Athanasius.
Thank
Jorge Rocha, we've done some research on ILM peel during retinal detachment surgeries. And what do you think, at least in our country here in Brazil, what the percentage of ILM peel that we do together with our retinal detachment surgery? What do you think about it? It's increasing, it's 5%, it's 15%, or it's more?
First, Olivia, beautiful Kate, thank you so much to present that. We have a lot of toxoplasmosis in Brazil, a lot of retina detachment. You did beautifully. And I agree completely with Athanasius. For retina, less is more. If you do less, less peeling, it's much better because manipulations, you can have so many complications. Even, that's the DONF, the dissociation of optical nerve layers, is not changing a lot of vision, but with microperimetry, you have loss of sensitivity of the retina if you do beautifully, but good case. And in Brazil, what I know that people are doing less and less peeling of internal limited membrane during vitrectomy for retina cases. All the congress that I heard, everybody is avoiding. Or the only situation that we can peel if you have epiretinal membrane, and sometimes when we remove a epiretinal membrane, it's so stuck that's come together with internal limited membrane, and then it's something that's unavoidable. But anyway, in Brazil, in the whole world, the people are doing much less limited membrane remove for retinal detachment.
Thanks. And please, Ahmed Habib, what, in this case, because you're going to present your case by now, but before you present your case, what are your comments on that? How much, what percentage would you do during the silicone oil removal after retinal detachment or during retinal detachment surgery? So when would you attempt to do ILM peeling?
So first, I would like to congratulate Olivia. It's a very nice case, so beautifully done. And of course, I commend you on the prophylactic, the antibiotics and the steroids before the operation. That's those details that matter. Actually, I would do the same as you did, but with some PFCL to avoid slippage of the retina. About the ILM, I would usually I do the ILM in the posterior pole if there is a break that is a break or a scar that is near to the fovea, because in my cases I see that there is an epiretinal membrane that forms usually when there is a break that is near, a break that is large, or the scar that is near to the fovea. So if this is the case, I remove the ILM usually.
Yeah, thanks for your comments. Would anybody like to comment on this case? And before we proceed to Ahmed Habib's case, and I think it's a great discussion. We know what we do different in different areas, so it's a very rich discussion. And so, Ahmed, please, you are fine to introduce your case. Are you ready?
So, is it shared? Can you see it?
Yes, it's visible.
Okay. So this was a case of a 14-year-old girl with a penetrating trauma that was repaired 7 months ago. As you can see at the site of the wound repair, there's a depression and a globe deformation at this site.
The image is not displaying yet.
Video is not coming.
Your screen sharing is paused.
You were sharing at the beginning, but now the video stopped.
We can see your
Is it okay now?
No, not yet.
No, we can't see the video.
Let's share again.
Just in case you cannot. Yeah, it's good. Yeah, it's good now.
Okay. So, as I said, this was a case of a 14-year-old girl with a penetrating trauma. As you can see, that the repaired wound has a depression and a globe deformation at the site of the old wound. This was 7 months ago. So I entered. I tried to take a look inside, but the crystalline lens was opened and contracted, so I removed it. I usually, when I remove it, I remove the capsule also. And as you can see, there's a closed funnel. I had to open the vitreous and the PVR, closing the retinal leaves to have a look at the retina. And as you can see also that there is a severe traction of the retina towards the old wound. So I started to work on and around this area of the wound, removing the vitreous anteriorly, and then removing the PVR. And then after removing the PVR, doing my homework, I proceeded with the retinectomy to sever the connection and sever the traction between the fibrous tissue of the wound and the retina. And then I proceeded for epiretinal PVR and subretinal PVR removal. Usually, I use a bimanual technique with double forceps to decrease the traction over the retina itself to avoid more breaks, and I go methodically from quadrant to quadrant, and removing this subretinal PVR plus quadrant, and checking for the posterior hyaloid, which surprisingly was still there and was difficult to remove. I used the cutter and the bimanual technique and even the ILM to remove it, and completed the PVR removal. And then seeing the wound itself and the fibrous like tether causing the deformation, I had to enter with the MVR. Of course, the scissors cannot overcome this fibrous tissue, so I had to use the MVR itself to decrease the fibrous tissue tether, and it turned out that it is a bridge that was cut. Again, this is a slower video. As you can see, an immediate recoil as soon as the fibrous traction was relieved, and the depression was gone, and the deformation was resolved immediately. And then I completed the retinal surgery, putting PFCL, doing some rotation to return the fovea to normal position, doing some radial cuts to increase the circumference to let the retina lie flat comfortably, and then removing the ILM just to make sure that the PVR over the hole was removed, and then completed normally the barrage and the silicone oil with PFCL exchange, and the retina was flat at the end, and the vision is improving. Thank you.
Amazing case, Ahmed. I couldn't believe when I saw at the beginning this flourished PVR retinal detachment, and you started with the anterior segment and then removed the anterior, doing the capsule rhexis, anterior capsule rhexis, and the whole thing came out. So it was not easy to see whether you could connect around in the teeth capsule rhexis, but then you remove the lens, and then the retina was so detached, but at the end it did not look so bad. So congratulations, a beautiful case.
Thank you.
So Olivia, what are your comments on your partner?
I want to congratulate Ahmed because this is a very difficult case, and I think you managed it since the beginning when you remove all the crystalline and directly to a bimanual technique. In these cases, you are not trying to do magic things, so you went directly to the heavy bimanual technique. You put everything, you remove all the PVR. I think you have a very nice case. You use the fluoro, the heavy liquid, in the good manner. It didn't went behind, so you did a very nice case. Congratulations.
Thank you. So about the PFCL going under the retina, if you can avoid indenting and removing and releasing the indentation so quickly, or using a high flow mechanism inside the eye, so as the PFCL would break into smaller bubbles. If it doesn't break into smaller bubbles, I think you're in the clear.
Yeah, I want to welcome also Dr. Lem, Professor Wai-Chin Lem, just arrived, and we know his time is a lot earlier than ours, 4 or 5 hours. So welcome, Dr. Lem, for coming.
Thank you.
And I know you're already warming up for your last presentation 2 from now with André Jucá. André Jucá said he did a very good case as well. And so I'm happy that you are around, and I remember in the events that happened those weeks and months ago, your picture with Vaibhav Sethi that is now back in India. So I just want to congratulations again, Panophthalmologica, for being with Retinawesome together again. And you know that you are part of the DNA Retinawesome as Dr. Lam. We started things together, and we are honored always to have you, Dr. Lam, here. And
Thank you.
Dr.
Thank you
Lam,
very much.
if you wanna, just comment on this case, this was very interesting.
Yeah, no, it's amazing. I think Dr. David has done an amazing job. I think he spent at least 2-3 hours in this case, and his meticulous approach, is what really makes the difference between a good outcome and bad outcome. And I think he emphasized, and I think those are many pointers that he has demonstrated in his surgery, particularly in children, to try to peel or separate the vitreous in a detached retina. A bimanual technique is essential. There's no other way. And he go after both the pre-retinal PVR and the subretinal PVR, and he takes the time to make sure that at the end, even though when the retina looks flat, he using the diamond dust scraper as a tissue manipulator to rotate the retina in the proper position so that the patient has right orientations of the object, the images, so that there's no torsions or like deviations of their visions. So I think the meticulous approaches is the key here, and he is such a very clever and very skillful surgery. So credit to hats off to Dr. Ahmed Habib.
Thank you.
And Ahmed, like Olivia, you both attempted to remove the ILM. That was amazing because in different situations, her case, the retina was better, and in your case, the retina had lots of PVR, but even though these PVR, you could grab the ILM freely and relieved.
So
those,
actually, to be honest, the ILM itself wasn't the goal for me. The goal for me was to make sure that there is no PVR, small PVR membranes or very thin membranes over the fovea. And as you can see, I couldn't remove it all, but the gist here is to remove the PVR, the small PVR membranes over the posterior bone.
Congratulations. And
Thank you.
I want to call for the next match. Dr. Marcelo Murilo Sasamoto and Dr. Professor Athanasios Nikolakopoulos. So, Sasamoto and Athanasios, are you ready?
I'm ready
Sasamoto,
when you are.
did you bring your gloves? Because it's tough, you know. Athanasios is very tough.
It's a winectomy that we're allies together. I'm not wrestling, so I can drink. And we need Hudson to be with winectomy together because we need a driver.
All right.
So Hudson is going to be the driver, and we're going to have the fun.
That sounds to me very good.
Very good. So,
share mine.
Marcelo, do you have your case handy?
So this is a trauma video that I prefer. It's a penetrating ocular trauma in a 3-year-old patient. So in this case, what we did, we found this big wound, zone 3, with sclera and cornea compromise. So we did a first surgery repairing a primary surgery repairing the cornea and sclera, and wait about 15 days to perform the first plana vitrectomy. When we performed the first plana vitrectomy, we found a retinal detachment all the periphery was really affected. And well, before that, we also worked with the other wounds around the eye, the eyelids. 3-year-old, we need to be very careful repairing and avoiding scars or minimizing scars. So 15 days later, we performed this vitrectomy, and we found a retinal detachment, a big regma in the periphery, and some small ones, also nasal and temporary. Then we put some laser, and at the end of the surgery, we finished with silicone oil. And we finished the procedure. My problem was 1 year later, I got this choroidal, small choroidal that resolves spontaneously and got no trouble. But my problem is right now, she had a band keratopathy. With the cornea department, we work with EDTA chalcesium, 0.1, 0.05 molar, and it works really well. In a zone 3, statistically, there's bad prognosis, 2200 or worse. So this patient had a hand movement 15 centimeters, and with the EDTA chalcesium, maintain this visual acuity. But the thing is that in the future, I need to remove the silicone and also maybe, I don't know if perform a corneal transplant. So I need some advice in this case. So would you be so kind to help me in this situation? Thank you.
Thank you, Marcelo. How long would you think you would wait until you remove the silicone oil, if you remove it anytime soon?
I'm really afraid of removing. Right now, patient is 5, but I think I need to do this year.
In such cases, to avoid, to keep following the cornea, as you said, you had this band keratopathy, you keep doing the microscopy or do anything else?
Right now, I have a accepting vision for surgery. That's why I was planning to enter in this 6 months, approaching the 6 months.
Okay, Athanasius, how would you comment this trauma? This trauma cases are very difficult. In case you keep the eye in a good situation or average situation, in order to avoid more complications, I think it's cool.
Recording stopped.
The way it was performed. So,
Well,
what's your opinion?
First of all, the most important difficulty is the age of the patient. The age of the patient is very important to understand. At such an age, you have multiple problems to face. First of all, the vitreous is another problem because it's very, very hardly attached to the retina. The second issue is that the child needs to have some kind of vision in order for his eye to be able to work in the future. And the third is that you cannot avoid the cornea problems when you have silicone oil, because the baby cannot sit in one position, and this is multi-difficulty. And band keratopathy that means that the cornea is drying out. And the drying effect of a cornea on a sutured cornea, on a cornea that has trauma, it's very difficult to avoid. And this is the only thing you can do in the future, is to keep any kind of vision the baby has, and keeping the silicone oil inside in order to have that. very reluctant to remove the silicone on this case. And sometimes you do complicated cases like the transplant, cornea transplant, and keeping the silicone inside until you feel safe to have the eye. And the other issue is that the eye is growing together with age. So you need to have, you don't want to have a microphthalmos or a nanophthalmos on the side. So you need to keep the blood supply and the living of the eye, even if he's not seeing very well, to keep it safe. So this is a very difficult case, and I think it's one of the most difficult cases trauma in children. It's a super difficult thing because you have to follow it for the rest of your life, not their life, your life. So if you start with that, you need to face it, and it's the psychological feeling of the baby, the kind of visual field the baby has, and also what is going to be the future of this eye. So it's not just one simple thing. And congratulations for taking task of fixing such a difficult case in such a good result. And when you have a good result like that, you don't want to sacrifice the good result by removing the silicone. You might. I have another thing that I can change the silicone. If it's emulsified, I'm using only 5,000 centistroke silicone oil, and I change the silicone oil, and I remove the old silicone and put some more silicone because I want the baby to grow with some kind of vision and to grow the eye together with the baby. This is a very important issue for me.
Thank you,
Thanks.
Athanasius. I believe it's it's a really tough situation with not only the patient, but also with the family. But I think a good option is to change the silicone oil, make a corneal transplant, and wait, and control this eye forever.
Congratulations for taking over this case, and credit for what you're doing. And I know the difficulty. You're doing a great job. Guanectomy is a fine way of doing things.
Thanks.
By the way, I want to comment also, as Olivia said, we have a Bolivian Congress, Retina Congress meeting in November, and if you want to join us, you're very welcome. We can coordinate and see us. Cochabamba, the place, the city called Cochabamba, Bolivia.
It's a nice name. Sounds good. Sounds great. But the thing is that I would like to everybody to have this opportunity to share the DNA of Retinawesome with the TVRS DNA, which is Thessaloniki with the Retina Summer School that is done the first week of July. And the first week of July in Greece, it's the beginning of summer, which is beautiful to be there. And if you want to have some information and contact with us, it's tvrs.gr, the website. Take a look and see if you can do it. We have about 40 people training 40 people, and the teachers are about 55. Can you imagine that? A wet lab with 55 teachers and 40 trainees. we win them all the time. That's why we want you on our side. But I would love, South America is too far away from me, and I haven't been familiar with that. So I would like to start up now with having such great surgeons. They live there, and I would love to come and see you from near. But the same invitation goes to Thessaloniki. Come in Greece. It's a little bit expensive now, but come.
Thanks.
Thank you, Athanasius.
Thanks, Athanasius. Thanks, Marcelo. And I know, Dr. Lem, you were in Thessaloniki with the Retinal Summer School last year. What are your thoughts on the event? How do you like it presentially? I participated online, so it's not the same thing, of course. So, what did you get to learn from this great event from Athanasius?
I think it is a unique training that was for anyone interested in VR surgery. As Dr. Athanasius said, the ratio of trainer to trainee is 1-to-1, if not more. And what's amazing is that there is all kinds of vitrectomy machines from every vendors that you can imagine that's available in Europe, and that allows people to practice on the different machines. And I think it's also well supported with the bionicle eye that you can practice on the surgery that is kind of almost in real situations. So the lectures that was provided there by the trainers and also top notched. So I think the trainee get more than they bargain for. Like what they pay for, it just in million times returned. And there's also this cohesiveness among the teachers, and we all can work together. And in fact, I learned a lot as a trainer from just participating as well, because they all sharing their kind of the pearls, their tips of how to do things better in the course. So I think it is an amazing and a great meetings for both the trainer and the trainees. And you have to be in person. And I think doing it remotely just missing the whole opportunities.
Well, it's the other part of the internet. There's no internet there. It's just you and the patient. So they cannot find in the internet or in the website or whatever they're doing the experience transmitted from one to the other. And it's a personal contact. This is very important. And I'm learning a lot from you, and I'm learning a lot from the other trainers. And we really enjoy it. It's like a party. It's a campus all together. And I think this is what we call DNA. DNA means people who like to give what they have, who like to give you tips, who like to communicate, who like to love other people. And if you don't like other people, you don't like to share knowledge, you don't have this DNA, so you don't belong to this party. So we would love to have you again. It is not 1 year, every year is different. Every year the weather is different. So we would like to have you next year. And first week of July, Lam, you are a participant and a teacher and a friend and a brother. So we'd like to have you again.
Thank you.
Thank you, Athanasius. And Athanasius.
Hassan, I just want to comment on Marcelo's case.
Sure.
There was amazing how the trauma case were able to salvage. I think the EDTA, we use it quite liberally to get rid of the calcium deposit, the band keratopathy. But in the long run, though, if there's plan to do the corneal transplant, you may want to look into creating either an artificial pupil or finding ways to separate the posterior segment from the anterior segments to minimize any further oil contact to the cornea. Otherwise, this will happen again in a few years, and then you end up repeating another graft or doing something to kind of salvage the anterior segment. So nowadays, there are opportunity with either sutures or artificial pupil, or even putting IOL that might be able to create the two compartments. So something that you may want to look into as the child get a little older and as you plan for your next surgery. But amazing surgery that you have done from the beginning. And like Dr. Tanasa said, taking on cases like this is not an easy task, and then you are committed for a long time.
Yeah, that's true. Dr. Nam, in case you had is corneal opacity over the months or even years, how easy you can get keratoprosthesis in case you need it to remove silicone, to see the eye fundus, and how do you manage that? Do you always have the anterior segment surgeon to cooperate with you together with those cases to put the keratoprosthesis over there?
So in my situation, we are fortunate because we are in the children's hospitals. So we do have the corneal specialist supporting. And so there is a pediatric the temporary keratoprothesis you can use intraoperatively, but in the long term, you need a corneal replacement, so a corneal transplant if needed. Then I don't do corneal transplant, I have to say. So the anterior segment surgeon will be the key to the successful management of complicated cases like this.
Okay, thanks. And now for
Sorry, Hudson. I wanna make a comment. I perform in adults this hashtag technique that Dr. Hanin from Brazil mentioned once in a Retinawesome, and it went very well. I mean, to avoid silicone oil going to anterior chamber. So that's one technique. And the other, like Dr. Lam said, is IOL fixation. Maybe when the patient had, the eye is bigger, maybe in the future. But those are my options also. Thank you.
Thank you. Yeah, hash technique is a fancy technique. If you could do it, it really works. We think that probably these threads, lines over there wouldn't do the separation, but they do. They avoid silicone oil from coming to the anterior chamber. It's a good technique. And now, Athanasius, you want me to share your case?
Yes, please. I think since I'm using my phone now, I'm
Sure.
home.
So
If you can put it on, I just want to present you some tricks and tips I'm using for a giant hair. As you can see, there's a giant
can
hair.
you see it in full screen?
Yeah,
Okay.
I can see it.
So you tell me
I can,
when to start.
yeah, just a minute before you start, because
Okay.
it's a very short video, 1 minute. The thing is that when you have a true giant hair, the difference is that the traction is not on the posterior flap, it's on the anterior flap. And that's the major difference between the retinal detachment and giant hair. That means that you have to remove the part of the traction that is on the periphery and not the part of the traction that is on the central area, which is, that's why they make it. And the other thing is that a huge opening of the choroid against the vitreous, and that means that you have a lot of pigment cells getting in, so there's a very fast transition from a giant tear to PVR, much faster than any other detachment. So the trick and tips is how to put the perfluorocarbon inside the eye without having slippage when you change to glass. So we need to change it from perfluorocarbon to silicone oil exchange, and not from perfluorocarbon to gas and then silicone oil. And in order to succeed that, I'm using the dual flute needle technique, soft tip flute needle. That means that I'm connecting one flute needle with my injection system that I have for silicone oil, and I'm injecting perfluorocarbon through the injection system. That means I'm using my foot pedal to inject PFCL. So I don't make any bubbles, and it's just coming one bubble. And on the other hand, because I'm using bimanual surgery, I'm using the tip of the fluid needle of the other fluid needle in order to suck fluid outside while injecting perfluorocarbon. And this way you remove the anterior flap backward. You can see now that I'm injecting in one bubble. Can you go forward, DK? You can see it's one bubble of perfluorocarbon, and with the other tip of the fluid needle, I'm just pulling away. And the way to do it sometimes is you have an infusion that is specially made by Med1. It's specially made for silicone oil. And if you can find that, because it's very rare to find it now, you can inject 5,700 silicone oil without any problem from the infusion line, and you don't have to use a special infusion for this. And this is an extraordinary thing happening, and people don't know it's existing, but it's Med1, and I'm using it so many times, and it saves a lot of things. So you see the 507,000 silicone oil, it's very tough, and but it stays there for a long time. And this is the tip of dual fluid needle removal of PFCL, injecting PFCL, removal of PFCL, and exchanging the silicone oil simultaneously. And you have to remember that in the vitrectomy, the alcon vitrectomy that I'm using has a dual foot pedal. What it means that half of the pedal, when you're injecting, you put perfluorocarbon inside the eye or silicone oil inside the eye, and the other half of the pedal, when you put it down, you remove fluid from the eye. So you can do simultaneously half of the pedal injecting, and when you get pressure, you just put the whole pedal down, and you remove fluid or PFCL from the other hand. So you can do it simultaneously. This dual foot pedal, if you don't know it's existing, ask the people from Alcon to show you, and it's going to be great to show that. Any questions, please? I just finished my presentation. It's just tricks and tips.
So, so it could bear 5,000 centistoke, and it doesn't, blow away.
How you can see it, I just showed it in the video, that it's the surface tension is so great that you can just see it. It's following the forceps that you're doing, and it's not coming out. The infusion doesn't come out. I close it and I put in the pedal, and I'm using 60 millimeters of pressure. That 60, and it doesn't come out. It's an incredible thing because it has dual system in closing it. I don't know if it's available anymore because people tend to do it from the injection side, from another side, but I'm using the infusion side, and it's a great thing to have. If you don't find it, ask Med1 if you can find you some.
Yeah, very good. And it's from Med1?
Yes.
Very good.
It's a small company that has a lot of little tricks and tips for vitrectomy.
Yeah, we have Med1 offered here in Brazil by another company with a similar name. It's MedVision. And so, yeah, those, especially the dual bores they offer, are very good as well. So you don't get pressure under, inside the eye when you have these closed systems. So you inject before carbon liquid and then don't have the intraocular pressure coming up so as to form any or to have any complication out of that. So I like their products.
Well, if you don't have any questions, I would like to tell you that my wife has entered the room and she's asking me to go for the lunch, Saturday lunch date that we have. So this is something we do in Greece every Saturday, lunchtime. So if I can be excused, I would like to go and see the family a little bit.
Sure, you're welcome. So thanks a lot for sharing your case and together with Sasamoto. And have a great Saturday.
It's a pity that we cannot go to lunch with Athanasius.
Yeah, this is a pity. That's why when you come to TVRS, every day for 1 week, we have lunch and dinner together, all of us. So lunch and dinner, it's different in Greece. We die young, but we enjoy life.
Thanks a lot.
Bye-bye, my friends.
Bye-bye.
Bye-bye.
Just want to say hello before the last presentation from Dr. Lem and André Jucá. My partner just arrived, and I thought he would probably have forgotten these gloves. So did you bring our gloves, Ahmed?
I didn't bring the gloves, but I brought a good video.
So everything is
morning,
fine.
Great haircut. Great haircut.
Thank you so much.
Younger every year. You're getting younger every year. Wow.
Thank you so nice so much, and great to see you all here, George and Wai-Shing and Dr. Sethi and Ahmed and everyone. Olivia,
Very good to see you, Ahmed.
thank you so
Good
much
to see you, Ahmed.
for being
Welcome.
here. Thank you, and Marcelo.
It was
Good
good to
morning.
see you presentially in those
Oh, Ahmed.
meetings months ago, the pictures with Ahmed and everybody else. And Roger Rocha is always present, so this is good to have our community well represented as well. So thank you very much. And Dr. Lim, were you there too? The last Beyond meeting or the next meeting?
Sorry, what's the question?
Did you were you present at Beyond meeting? I think I
No.
saw a picture from you. I don't know whether it was
Beyond.
Beyond meeting.
Oh no, I
or-
met with Wai-Shing in Kuwait recently.
Yeah, in Kuwait.
Yeah,
Yeah.
Kuwait.
Yeah. It was really fantastic. The weather was fantastic, and of course the company as well.
Yeah.
No, it was wonderful. It's a nice
Yeah.
break from the Canadian winter.
Dr. Lam, I remember, live surgery in Kuwait that you participated some years ago with other retina surgeons, and was that the same event?
Similar, I also did live surgery in the hospital there. They collect some unique cases, some challenging cases. It was a great opportunity, a lot of fun with the colleagues in Kuwait.
All right. So, Salam, you're ready to present your case? Would you like to share it by now, or you want me to share mine first? I think he's out for a while. Probably he got disconnected, but he's gonna come back in. So I will present my case.
It's full. I think
Oh,
full
yeah.
screen.
So it's a 3D video. You know, I like to present 3D videos, and in case this is a diabetic retinopathy proliferative case. The thing is that how far you should go. You should do more surgery or should less surgery. This patient in 2022 had this right proliferative vitreoretinopathy, but with time he was getting worse, and he was losing all his follow-ups. He was not coming to the clinic, and his left eye was just like that. His left eye had this very proliferative vitreoretinopathy and the retinal detachment. This was the right eye. The left eye was fibrous tissue, a diabetic patient, and this was his left eye. So the thing is, uh, when you imagine 2 years ago, and actually less than 2 years, 1 year and a half approximately, you have this proliferative case here with new vessels on the retinal surface. But then you come up with the surgery. 2 years ago, it got so worse. So, how can you reach down this fibrous tissue here to do a good surgery? Because the left eye was too bad. So, as I show you here, the left eye has this previous retinal combined tractional retinal detachment with this funnel shape, and so the outcome was too bad. So I decided to do surgery because the patient finally showed up almost 1 year and a half later. That was the situation of the good eye. So should I do more? Should I do less? And how could I relieve those tractions without getting anything worse? Because it's already very bad. So removing here the vitreous hemorrhage and the hyaloid, disconnecting the hyaloid from the retina itself and fibrous tissue was not easy at all. Because if you apply too much force, you could well create this large hole, and trying to remove and separate here the fibrous tissue from retina was not a very easy task. So the thing was not to do too much, to do less is more. So I'm doing here the removal of these fibrous tissue band like that. So with the cutter, it got relieved. So I was happy about that. I just wanted to trim it a little more. And if you want to do more, sometimes you need another hand. And my other hand, as you're gonna see here in a few seconds, is perfluorocarbon liquid because it counteracts your actions and you can actually approach the retina without causing too much traction on your side, like pulling the retina here and there. So perfluorocarbon liquid was the next step of the procedure. We had these active hemorrhages, and also the advantage of perfluorocarbon that it's gonna halt these hemorrhages. You have this epiretinal fibrous tissue here. I'm trying to relieve as much as possible with this 25 gauge special forceps serrated one to remove the and pull up the fibrous tissue very carefully. And now doing the photocoagulation. And because the last case, I mean, the left eye of this patient was so bad, and this could well come to be the retinal detachment. I did this direct fluid exchange, I mean, silicone oil perfluorocarbon exchange to get the retina attached at the end. And it got actually beautifully attached like that with endo laser. And in such a case, I'm just waiting for some time because the patient is phakic. His lens is a little, is still very clear. I don't want to leave silicone oil for a long time. So to keep the lens clear, and after it gets stabilized, I will remove the silicone oil. This is the way I do the direct exchange. So I hold the infusion line uh, like that, and after holding the infusion line, the silicone oil is injected through the infusion line, and I remove the perfluorocarbon liquid with the backflush cannula like that. So you've got this better control of the pressure and what you are removing. And I remember Dr. Ahmed Salam explaining in some of his earlier videos. And of course, in this case, is 23 gauge cannula, backflush cannula. But of course, if it was 25, I would better off opening up the sclerotomy site and inserting this 23 gauge. Otherwise, I would have a very high pressure inside the eye. So the end result was that, and the patient got a lot better. Thank you very much. This was a tough case, and the discussion here to open for you is whether to do more or to do less. And of course, I think I did what was enough, because if I hadn't removed those tractions, circular tractions, fibrous tissues around the macula area, the retina would be detached. And as you saw, the left eye had this funnel-shaped retinal detachment, and things could get worse in the very short time. Thanks.
That's a beautiful, really, Hudson. It's a beautiful case, and the exchange is beautiful. The direct exchange. I think there are lots of tips in the direct exchange, and whether passive or active direct PFCL silicone oil exchange, and many people shy away from direct exchange, although it's good, it's quicker, the visualization is very good. If you have a giant break or retinectomy, your slippage risk is very, very low. But I think in many fellowships it's not taught, because there are sort of like tips and tricks and in this technique, and you can have very high pressure with the passive technique. So I think that's great. That's a beautiful exchange.
And so, what are your comments on the exchange of the gauge? Like, if you do that in 25, and of course, the direct exchange could cause, very high pressure on the optic nerve.
Yeah.
So, how do you enlarge your incision? You just remove.
Actually, I'm thinking maybe my presentation, I'll change it. I was gonna change on present on the diabetic case, but I actually have a demonstration for the passive and active with some details, and I think since you and Thanasius touched on this, maybe I can explain it a little bit further what I do. I think that may be nice to, like, especially young surgeons watching us.
Yeah.
So when I present,
Yeah,
I can.
you can present it right now, please.
Okay.
Are you ready?
Yeah. Let me just get to my drive because I'll change the presentation. Okay. So this is from we have a book just came out. It's called Vitreoretinal Surgery Manual. I hope that young doctors, and I mean it's mainly really for young and for established surgeons, all about tips and tricks and how to do this, how to do surgery the simplest way. And I have the honor and the pleasure of editing this book with Jim Paolini and Ferin Kuhn and Ron Edelman. It's called Vitreoretinal Surgery Manual. And these are some of the videos there. I'll show you the passive exchange first. The passive method for direct curve workup. Let me here. Can you see my screen?
Yes.
Okay,
So,
I'll show you different things here, and really would welcome your feedback. And I really I find this area of the fluidic exchange very interesting. So this is a setup here of the passive exchange where you have the light pipe in one hand, the passive aspiration. So this is a passive aspiration; it's not active. And then you have the silicone oil going here, the injection. And that here is the setup to show you here. So this is you have the passive exchange here. And another modification, because sometimes, especially when you're doing 25, if you try to inject through the fluid line like here, the oil gets the cannula to shoot out from the trocar. So another modification, especially if you're using 25, is to do it like this. You have the passive aspiration in your hand, you have the silicone oil injection in your hand without the cannula, and the problem is the light pipes, so you're going to use a chandelier. So that's a modification, especially if you're using 25. And that, again, here is all passive. Now the technique starts like this. So this is exactly what you want to achieve. You have the PFCL here in the retina, the silicone oil is coming, and you see in Fig A, and very important whether you're doing passive or active exchange, the tip of the back flush should always be in BSS or PFCL and never in oil. Because if you put the tip of the back flush, whether you're doing active or passive in oil, it's going to block the back flush, and that can be a problem. So the ideally is you go on top of the PFCL, and wait for the silicone oil to come. Then after that, you go to the brake and dry the brake, and then you move to the remove the posterior PFCL. In reality, you don't need to dry the brake much if you're doing the direct exchange, because what happens is the silicone oil and the PFCL both are hydrophobic and they join together so much well. So actually, you can, once the oil comes in to join the PFCL, you can go to the disc. But ideally, you want to drain to avoid slippage, but usually slippage does not happen if you don't run into hypotony. And with the passive, you don't run into hypotony. So here, and this is the technique is going to start in a second. That's what you're trying to achieve here. Right. So another modification for the setup is to do actually, because the problem with the passive, the injection of oil is active, but you're removing it passive. So there's a pressure rise, and that's why people shy away from this technique, because the pressure can go very high in the eye. And actually, I'm aware of a case like somewhere where the eye even ruptured because the pressure went so high. So one thing which we thought of is to do a mismatch between the injection and the aspiration. So if you're injecting with 25, you can actually aspirate with 23. This increases the efficiency of the procedure 1.5. When you have like a just one gauge mismatch, if you mismatch between 25 and 20 aspiration, you increase the aspiration of PFCL by 2 times, and we measure that. So this is here the mismatch, and these are the numbers here. Okay, whether you're doing active or passive, the best thing is to do is to get the infusion cannula primed with oil. So the cannula is ready, it has oil in, and then you put it back. So you take it out, you prime it with oil, and you put it back. And this is the technique from outside and from inside. So what you're doing is you're injecting the PFCL, and you go and once the oil starts coming, you go to the break and wait till the break. And then once you see the bubbles coming, then you can move to the disc. In reality, you actually can move to the disc once the oil comes in because slippage does not happen. And then you follow the bubble and you try to get it in one wave as it's here. And the visualization with direct exchange is very good. And then you follow the bubble and then finish off. And then I usually would suture all the cannula. One thing which is important is to make sure that the pressure does not go high with the passive. And the way to know the pressure is to look at the disc. If the vessels are winking, the disc is going pale, or also you can press the instruments together. It gives you a nice tactile feeling. Then you ease off the injection if that happens. And then you suture. And again, just a revision here of the technique. So that's the passive. So I now can show you the active, but any questions on the passive technique or any points you want to
very cool.
me to illustrate? But I think, yeah, the message is at all point, whether active or passive, the back flush should never be on oil, and also to prime the infusion cannula, and also to know that if you're doing the technique well, you don't need to drain much on the break because slippage would not happen with the passive exchange. The problem with the passive exchange is the high pressure. So then the active, which actually Thanasius showed on the machine, and I'll show you the setup.
Setup
and again,
is not very different.
Sorry, I'll put the voice off. Okay. So it's not very different. Again, you prime the cannula with oil, and you put it back. And the eye is really like nearly filled with PFCL. There are some techniques where you have to insist, by David Wong, that you have to insist that PFCL is filling the eye and even dripping out of the infusion. I don't think you need to do this at all with the direct exchange, because slippage, if you're doing it well, slippage would not happen. But again, same point here as we discussed.
Yeah,
What is the injection pressure for the oil?
I'll show you in 1 second why she's gonna come in a second. And again, same here. You go, oil comes in, you go to the break, and once you start seeing the two bubbles together, and you see here a bubble and then a bubble outside it. That's actually DSS outside it. And then you can go to the disc, and I'll show you here the numbers, and I'll show you what happens exactly on the pedal in a second. And then you go here and you drain. And this is here the nice part. So it's usually with the active, we go 250 and 30. And that's usually gets the number right. And this is how to set up the machine. So when you go to extrusion, if you're doing passive, then the aspiration, which is on the top, the vacuum is usually switched off. If you're doing active, then you switch that on. And the numbers is about 250 and 30. That gets it right. And then here, look what happens with the foot pedal. And I've made like a demonstration here. When you are on foot pedal 1, like here, what happens is just you're injecting. So no aspiration. Once you go to, and then it's set at 30. Once you like pass the 1 and you go more on the foot pedal, the injection is maintained. If you look here, the 30 is maintained, but then the aspiration now is kicking in. So that's how it works. So ideally, what I do is I actually press. I work on a like a reverse pedal. So I press the pedal all the way down. So you have injection and aspiration. Then if you feel the eye is going in a bit of hypotony, then you ease off the aspiration. Because remember, the pedal is actually, when you are 1 here, you're only injecting, that's the first part. And then when you go more, the injection is maintained, but you're aspirating. So I work on a reverse pedal. So initially, once I start, I actually push all the pedal down. So I'm injecting and aspirating. And then if I want to stop the aspiration, then I ease my foot off the fuel pedal, as I call it.
Can you do that
And then
with the
yeah,
pedal?
go ahead, please.
With the pedal, you switch.
With the pedal, you don't. Imagine like a gas pedal or a fuel pedal. Once you just like press half the pedal, you're only injecting,
Okay.
and that's here. Like, see here, this is 0, nothing happening. When you go to 1, which is like half the pedal, you're just injecting. So you see here, like this is here, like the arrow here on that side picture where it says foot pedal, that gets you to 0, from 0 to 30, the injection. Then as you press more, then you go now, the injection is maintained, but the aspiration kicks in, and you'll see it now playing.
All right. Yeah.
So actually, if you want to inject and aspirate, you just step on the pedal fully.
So I
And
would
then
like to make a small comment. There's also an option that is unpopular in the same machine that you can skew between, that you can change between the pressure on, pressure off, injection on, injection off, and injection and the pressure and aspiration on. You can change between them in the same PFC program. There's an option in the machine that can let you do that. So as when you see that there is a hypotony or increased pressure, you can change the injection or aspiration to be single aspiration or injection, not both.
Interesting, right? Yeah. So this is the way I do it. So I work like a reverse pedal. Initially, I would step all the pedal in, which is injecting, aspirating, and then as you want to aspirate less, because there's a bit of hypotony is gonna happen, then I just ease off my foot and I go to position 1 where I just injecting. But so I think you just need to get used to it, play with it like before the case, and just get used, because you're working like in a reverse pedal. If you want to actually aspirate less, you have to like don't press more. You actually, if you want to like less aspiration, you have to ease off the pedal. But that's how it works on this setting. And yeah, and again the same, and you follow this. It remains that this is a good one here, the last bubble. So that you have the last bubble here and it didn't come out, and you want to remove it. The worry is that if you're injecting and aspirating, the pressure can go very high in the eye, that even that pressure may get the retina to jump up and you can hit the retina. So one way to do it is to actually use a passive aspiration at the very end. And I'll show you how that works. So this is how it works. So what you do is you do it passively, but to raise the pressure a touch, you just press with that finger. So that finger there, holding the back flush, you just press on the eye, and that raises the pressure, and then you get it with passive. That's something, I think, a tip is that it has been passed from one surgeon to the other over the years. We didn't find it really written in books, but you want like a bit of a raised pressure. So what you do is you just press with your finger there. So there are lots of things to do with your fingers when you're doing this exchange. One is to press the two hands together to have a feeling about the sensation, and the other one is at the very last bubble, you do it passive, but you just press with this finger there to raise the pressure, and that gets you a raised pressure to get the last bubble here. Yeah, and that's a 3D. Yeah, so it's this finger there, so it'll be the the index of the right hand, this finger. You just press it.
So, Dr. Salam, in your technique, if the pressure goes too high, then in that case we'll have to. We cannot use the technique. That means because if we inject full throttle, then we also. When we aspirate, we're also injecting. There's no option of pure aspiration without an
Yes,
injection.
but usually with the active exchange, there's pure aspiration. You're right. So I think you can switch off. So I think it's better avoided. This situation usually in the active exchange that does not happen. On the active exchange, the problem is actually go more in hypotony, and with passive exchange, you go more with high pressure. But what you can do is you can switch off the injection from the machine. And maybe I don't know if that was Ahmed speaking about, because you see like here, you have the two options. You see these like green buttons there, so you can switch it off. But usually you don't go into high pressure with the active exchange. You go actually more on low pressure. You have to be careful not to have low pressure because that can cause slippage. But otherwise it goes seamlessly. Yep, I think.
Ahmed,
Any other?
in case you got trapped, you are doing your direct exchange, but then the system is closed, like the trocators that don't flow, and you are pressing step one. You just the pedal step one, and then if the pressure gets high, and then you go pressure step two because you're gonna aspirate, even though the silicone oil keeps coming in, so still you're gonna have raised pressure. So what would you do in this case? Would you disconnect the injection site of silicone in order to relieve?
Yeah, I think
the
that
whole
was
pressure?
what Sethi was asking. Yeah, I think you can switch off the injection, but I think that situation most likely what happened, you had the backflush in oil and the backflush got blocked, or the whatever you call, or the active extrusion in this case. So I think be very careful not to get the extrusion or the backflush in oil. It always has to be BSS or in PFCL because that's blocks it. And the second, if you run into this, you can switch it off. But I did not run into this before with the active. On the active, actually, the issue is that you are more to run towards hypotony.
Okay.
But always, if you find the disc in passive or active, if you find the disc winking, the vessel's winking, and the disc is getting pale and the pressure is high, you have to think of easing off the injection. The other one you have to think of, which is very important, is that you had the backflush in oil and it got blocked. So you get it out and flush it with BSS.
Yeah, beautifully presented, beautifully, and also you have your finger, so you could feel how the eye looks like if it gets raised pressure or lower pressure.
Yes.
This is a good thing too.
Yes,
You always feeling.
it's like you can use it with your finger, or you actually press slightly the sclerotomies together and give you a tactile sensation. So maybe again for the young fellows or young surgeons hearing us, when you do a vitrectomy, to get a feel to the eye, you can feel with a finger, or you can press the instruments together and try that. Just a little bit of pressure, it gives you a feeling about how the eye is doing.
All right. Thank you very much. Thank you, Jorge Rocha, for participating with us in the name of Braves as well. And I really appreciate. And for the last match, could you please, Jorge, announce the main fight between André Jucá and my dear Professor Wai-Chin Lam? Could you introduce them before you leave?
Of course. Thanks so much to join you. It was a great pleasure to see all my friends here. I hope to see you all face to face very soon. And for the last fight, we're gonna have André Jucá from Brazil and Dr. Wayland Lam from Vancouver. Welcome.
Thank you.
you.
Dr. Lim, did you bring your gloves?
Bye.
Bye. So, André, if you wanna share your case first, please.
Okay.
Are you ready?
Yeah. Okay. First, I would like to thank you for the invitation of participating in this special session of Retinawesome. It's a pleasure being making this duo with Dr. Lan. It's really very nice. I brought this case that is from a male man of 40 years old. This happens to get in contact with us 3 days after a penetrating ocular trauma. And we could notice there was a corneal perforation, a cataract, and the ultrasound, as we can see here, showed this intumescent cataract, but with a posterior capsular rupture. And the ultrasound also revealed an intraocular metallic foreign body with posterior shadowing in the ultrasound. Although we couldn't see much, we could already see there was this situation. The eye was not very inflamed, so we went right away, but already after 3 days of the intraocular trauma, to a corneal suture. Then we did phaco aspiration, pars plana vitrectomy with a PVD, and then we used the 20 gauge intraocular magnet that is very nice for removing these foreign bodies. We notice, and you can see in the video, an extensive occlusive vasculitis. So we decided to perform a pan-retinal photocoagulation. Afterwards, we put the intraocular lens in the sulcus with pieces, and then silicone oil, and then antibiotics. There is a nice surprise in the end. Here is the video of all the steps that we just said. The corneal suture, and then the phaco aspiration. Of course, there was this rupture anterior as posterior that we saw in the nicely in the ultrasound. And this we are aspirating the crystalline lens. It's very soft, very young guy. And then there was this kind of endophthalmitis that we saw. There is the intraocular current body. We to use the magnet, we have to make a 20 gauge incision, and then you see that it's very easy. The magnet just come right away. We put it the foreign body in the anterior chamber, but you have to orient it to extract in the minimal diameter. So the magnet here helps again, and it's really very convenient. But look at this very occlusive vasculitis. Then we were afraid that maybe the patient will get neovascular glaucoma and the PRP. And then we put the intraocular lens, and then silicone oil was injected. This is 20 days after the surgery, and this is 20 days after the surgery. Okay. This is the next slide. And here we see that the vasculitis reversed. So we have here no perfusion, and here we have nice perfusion. So when we treated the patient, removing the infection with antibiotics, removing the foreign body, the inflammations also decreased, and the capillary and vascular retinal circulation was reestablished. And we found out this very strange bug, a Microbacterium paroxydon. And they found out firstly about it in 2003. It's the first report of intraocular infection with this bug that I learned that can happen in immunosuppressed patients and patients that has cannula is in intensive care, and has been reported some strains may be resistant to vancomycin. We use the combination of vancomycin and ceftazidime in this procedure, and it rarely causes eye infections, although it can be easily found on soil, water, and even fish like tilapia. That's the first case of endophthalmitis for this bug, that the Microbacterium paroxydon that we know, but it only happened because the foreign body drive it inside the eye. So this is the eye at the end of the procedure, and the vision improved from light perception to 2400 after 20 days. And there is still this corneal scar that we are going to deal with after we remove the silicone oil. But here you see the biofilm that's covering, it's produced by the bacteria and it's covering the foreign body. It protects it from the defense system of the eye, of course. That's why it's so important to do the surgery as soon as possible in these cases. It is very important also to try to find out which bug you are dealing with and which kind of resistance they have, because sometimes, as we learned, there was some strains is resistant to vancomycin. So in trauma case, never give up. Sometimes we get some vision improvement besides saving the eye, even in tough cases like this one that arrive a little bit later than we wished. I would like to thank you, everybody.
Thank you, Andrea. Such a nice case and difficult. And when do you decide for trauma cases like that? And you supposedly get an infection. So how do you get your culture, antibiogram, and things? And how do you do the setup to collect those materials?
Well, we take the fluid from the vitreous cavity and also the foreign body. I think it's important to send it to culture. Of course, you do not have to wait to immediately initiate antibiotics. We use also oral Avalox as an adjunct, but we think that the main treatment is intravitreal antibiotics like vancomycin and ceftazidime. Amikacin is also a nice option, but we, in this case that we made a lot of exchange, we were afraid of toxicity by vancomycin, by amikacin, aminoglycosid.
Oh yeah, I think you can get away with that with both drugs. Yeah, but still, if you put the right dosing of amikacin, I think it could help as well. But in case you think of fungi, uh, what will you do? What could be your prophylaxis?
Yeah, for fungi, it's amphotericin B, the drug of choice. But I do not use fungi unless it's vegetal intraocular foreign body, because amphotericin B, even it's kind of toxic for the retina. So at first we do not use it because there is a metallic foreign body, but we wait for the results. And indeed, the patient increased very fast after the surgery. And when the outcome of the culture arrived, the patient was already better. So that is the most important thing for us is the response, the clinical response of the patient.
Beautiful case, very very well recorded as well. Vibhap would like to comment.
Yes, but Andre, very nice case. I liked it, and I like the way the vasculitis reversed very beautifully post-operatively. And one question I had at the end of the surgery, I've seen there was a corneal tear, and this oil, I think, popped out from the corneal tear as well. This at the end, and you push it back.
Yeah, no, to keep the oil down because you have not a good separation between the segments. But to keep the oil out, we use viscoat, and it was the viscoat that was coming out.
Viscose. That was the oil, yes.
So the viscoat avoid the oil coming to the.
All right, Ahmed, wanna comment?
Sorry, this is a great case. I really enjoyed it. Thank you so much. I just have a little tip, something that I've been doing for several years now, how to remove the foreign body, because the problem, as Andre beautifully showed, is you have to enlarge the sclerotomy to 20 gauge. Can I just show you a picture of what I do, like a different?
Sure.
Is that okay? Yeah. All right. This is here what I do. Very quickly. So this is a patient who again had intraocular foreign body. We have a 23 gauge setup and cleaning, and we did phacoemulsification. And then here is the foreign body. I'll cut to the important part. And the lens has dropped to the back of the eye. So this is the foreign body just cleaning. And then we remove the sorry, I just want to show you the part which is important. Okay, propagating the PVD. But the thing is, you can see it here. We introduce actually the magnet through the corneal wound. So it gets you a little. It's a little bit of a weird angle of attack, as you will see here. But you actually can compensate for it very nicely. So I don't open the sclerotomy. I just go through a corneal paracentesis or the phaco wound. It depends on the size, and that's usually in patients who are rendered aphakic at the time of the surgery works so well. Then I just don't need to enlarge the sclerotomy. Again, it's slightly a bit of a weird angle of attack, but you can compensate for it. That's what I do.
Well done, yeah, that's a nice option. Yeah.
Yeah, and usually you can get away with it once you get everything ready, but you just need to compensate for the angle of attack a little bit because it becomes a bit weird.
Yeah, in your case, you were very well done because the cornea was very stable. Sometimes when you go through the cornea, it gets a little.
Yeah, and the wound has to be not so large. So, but usually, I would say in this situation, 99% if the patient is rendered aphakic at the time of surgery, it works.
Thank you for your tip. Nice tip. I will try next time.
Very good technique. And before we proceed to Dr. Lam's case, Dr. Lam, would you like to comment on this such interesting case from André Joca?
Yeah, no, it was wonderfully done. And I think that Dr. Juka said it correctly, that timing is everything. I mean, with a case of trauma and perforating injury with intraocular foreign body, the sooner you can get to the surgery, the better the outcome is. And I think gram-positive organs particularly are bad with exotoxin, and that causes a lot of inflammatory reactions, and so as the vasculitis. And good thing is that once you have the infection control, the vasculitis is reversed, and that may be a place where intravitreal dexamethasone may have some benefit to calm down the inflammatory reactions. Like I said, gram-positive are particularly bad, and but I think the patient is fortunate. And the use of silicone oil to help to reduce the inflammatory or infectious risk, because oil is bacteriostatic. So the oil itself may also help the eye to settle down and prevent the detachment. Not only that, but also allow the infections to clear up faster. So all done well.
Okay, thank you very much.
So, Dr. Lim, are you ready?
Thank you. Yes, I'm going to go to share screen. Go. Okay, so well, thank you for the asking for the kind invitations, and especially here with Dr. Zhuka is a wonderful opportunity, and because the time zone differences, I appreciate that I was allowed to go later. Oops, I think this was on auto, so just 1 second, and let me go back. I think it went to, so just one more time. Here we go. Just go back. So we have a young patients here with morning glory syndrome. It's an 8-year-old girl with relatively good health, and I think it's on autoplay. So it's a left eye with morning glory syndrome with total retinal detachment with like PVR. And so here's the fundus pictures. You can see the morning glory syndrome with the detachment, and in addition to that, you can see some fibrous proliferations, temporary neovascularizations too. And so the surgery is what everybody probably would expected, using the triamcinolone to allow better visualizations of the vitreous and creating a PVD. And there's some glial tissues at the optic disc, which is also classic in the cases of morning glory syndrome. And that was removed, and then tried to remove the vitreous attachment. And the young child is very adherent, using the forceps and the light pipe as a bimanual technique. There was a little bit oozing from the disc. I think that might be from some of the vascularizations that was there, and just continue to trim the vitreous. And so taking out the clot from the disc, try to identify if there's any retinal break. In this case, we couldn't find any breaks at the center of the morning glory syndrome, so decided to make a drainage retinotomy and flatten the detachment. And that went very well. And after that, we did laser around the retinotomy and 360-degree laser around the optic nerve. And the intention is that most of the time the break is actually at the center of the coloboma, and by doing the laser, it will help to keep the retina from detached. And I put gas in, this time C3F8. And so I thought surgery all good, and I should expect a good result. So the next day, I noticed there's a small air bubble in the subretinal space right next to the optic disc, and I didn't make much of it, and I thought this will settle down. And then what happened on the day 7, we have a bolus retinal detachment right against the disc with subretinal gas. So it appears that the gas might have found its way into the subretinal space and then causing the detachment. So why did the gas get subretinal space? Now we have a bolus retinal detachment of gas, how to drain it, and what are the way that help to prevent the gas from getting into the subretinal space. Just a quick review of the second, the just want to sorry about this. I just need to okay, because it was blocking me seeing my slides. So the mechanisms for the optic nerve pit and Montgomery syndrome was thought to be a spectrum of diseases, and I can't. You know what? If you don't, I'll stop sharing. I will share again. Sorry about this. And okay. So the key to understand this condition is that this is often lie within the defects lie within the center of the disc, and most commonly you have this defect at either at the center of the excavations or at the border of it, and it's associated with peripapillary pigmentary disturbance and the abnormal retinal vasculatures, and the bleeding that we saw intraoperatively may be from that, and it's likely because of the communication between the vitreous cavity and the subretinal space where the gas bubble may have went into it, and so this is one of the kind of proposed mechanisms of how the optic nerve pit, optic nerve coloboma lead to retinal detachment. And of course, the other theory may be from the CSF, but in our situations here is most likely from the communication between the optic pit and the subretinal space. So we went forward to do the surgery, and to drain the subretinal gas was actually much easier than we thought. And because once we actually entered with the trocar, we were into the subretinal space, and then the gas bubble was drained through the sclerotomy site. And then we completed the lensectomy. We went in and we removed any of the residual hyaloid, and you can see there was still some residual hyaloid that was left despite the extensive dissections from before. And during the peeling of that vitreous membrane, there was some iatrogenic break that was formed. So using advantage of that to drain the retina and drain the subretinal fluid. So now the retina is flat. So I laser the breaks, and what I don't know, people notice right there. So this is the optic nerve, and there's a bubble of air pocket right next to it during the while I was doing the laser. So soon as the gas find its way into the subretinal space intraoperatively, right on the spot. So this really supported the proposed mechanisms of how the optic nerve communicate with the subretinal space. In fact, we see that right in front of us. Well, I was quite amazed. I just want to draw back a bit so you can see right there. See the bubble form. So what to do next? Now we know that there is a communications. So and in order to prevent the recurrence of the retinal detachment, especially with the gas now into the space, I decided to use some after draining the fluid using Tissot. So you see next, once we done all the laser, we're going to cover the optic nerve with the Tissot. and it forms a fibrin groove covering that, and before the groove form, more gas actually get into the subretinal space. So once we flatten that, I drain the subretinal gas and laser that area where the gas has entered, and so that's the end of the case. Oops. So the surgical challenges for the Morning-Glory syndrome is that number one, laser uptake around the peripapular area is not so easy because of the hypopigmentations, and you saw the difficulty detaching vitreous because of the young ages, and they often very firm vitreous adhesions as well as vitreous schisis. And I would suggest and recommend try to avoid PFCL. If you see this case, you know that PFCL can easily migrate into the through the optic nerve pit, either to the subretinal spaces, which is problematic, and or the subretinal space. And then, unfortunately, just as this case example show that this often happens in children, and with the retinal detachment, and when they present it, they often present late with severe PVL. So you need to manage both the challenges dealing with the detachment as well as this PVL. That's the end of the case. Thank you.
Very well made, Dr. Lam. I've seen many procedures. You're doing the glue. When you inject it, it works right away. It seals the defect.
It's a mixture of two solutions. So when they are come into contact, they become a fibrin type of glue pretty quickly in less than like 10 or 30 seconds. They will form a adherent kind of fibrin patched.
And do you think, as you said, the vitreous for these pediatric patients is very difficult to remove? So any tips on how you do that? You always stain the vitreous?
Yeah, I think visualization is the key. So using triamcinolone always helped to identify the vitreous well. And because it's very adherent, I think you've been shown by Dr. Habib, Ahmad Habib, showing the bimanual technique to try to separate the vitreous. You can either use two forceps or using the light pipe as a second instrument to stabilize the retina and try to peel the vitreous. And using the instrument to pull the vitreous tangentially away on this retinal surface rather than try to tear it off, because retinal break can occur. In fact, in my case, in the second surgery, during the peeling of the vitreous, I created an iatrogenic break because of the very adherence of the vitreous to the retinal surface. But you need to be aware of that, and then you trim them once you are able to separate them.
All right. André Juca, your partner, could you comment on this great Dr. Lam's case?
Yeah, it was a great case, and some decisions avoid a worse scenario, like using silicone oil and perfluorocarbon liquid. Much better have gas than silicone oil or perfluorocarbon liquid. But it really is hard job removing the posterior hyaloid in these pediatric cases. They're like chewing gum, very sticky and very hard to remove. But it's a very hard case. In Morning-Glory syndrome, you can sometimes, many times, not finding the real break. Maybe it's one of these cases that I would like to enjoy to have an intraoperative OCT to try to see if we could find something. But it was nicely done, and many lessons, and really it was a really good choice going to gas in these cases. silicone oil is risky, and as is perfluorocarbon liquid. Even there is some reports of silicone oil end up in the brain. Thank you. Congratulations, Dr. Alan. Wonderful.
Thanks. Thank you.
Dr. Lam, excellent case. I think we don't get to see such cases very often. Thank you for showing us a very rare case and a rare complication, because such cases are very complex. We don't understand the anatomy very well. My only question is, when we made the retinopathy the first time to drain the fluid, you think we could have also injected subretinal blue? Maybe that blue could have also found us the primary break. This is in retrospect, because when you're doing this case, these questions don't come up. And do you think using an AMG graft could also help in plugging the excavation site? Would that also be equally effective as a glue?
Yeah, no, those are excellent suggestions. I think that using the tissue blue or brilliant blue or trypan blue into the subretinal space to try to identify the locations of the defect may help. In this case, it's a chronic detachment. Sometimes the break is well kind of hidden within the scar tissues, and they may not easily kind of drain. But that is an excellent recommendation. In terms of using the amniotic membrane as a cover, I didn't think of it at the time because I wasn't kind of thought of the need to cover the defect, because I didn't expect that such a readily communication between the disc and the subretinal space, and only found that out post-operatively. And when I went in, I thought if I drained it and then I laser it, it would be fine. But then during the airflow exchange, I already realized that there's complications. If I would have the amniotic membrane ready at the time, as in preparations, then that may be a very good idea. But in a very kind of on the spot decisions, it's much easier to get tissue like the tissue, which is in the fridge, and in the neurosurgery as well as cardiac, they have that, so I can access that quickly. So that's the reason why we use it. And we know that the glue will dissolve after about a month. So fortunately, there might have for the kid, there may be some scarring form, so that whatever defect was there did not recur. But if it recur, I think the amniotic membrane or some people use scroll tissue as a plug works well as a way to prevent further complications. Quick suggestions.
Thanks.
Wai-Ching, I have a very quick question. I've used the Tessia several times, and I've always not been sure whether to use the more fluidy one first or the thicker one. I mean, I think I've done this and I've done that. I found no difference. Do you have any thought on this or any preference? Or
Yeah, I like the more fluid one because because the design is that you have this kind of cartilage when they come, as you push, they join together.
Yeah.
The kind of injection port, and then they get mixed. And I find that sometimes what happens is that when they mix, it mixes too quickly and they start to block the injections. So what I did in this case, you may not have noticed, I injected the two components sequentially. So I let them mix inside the eye, especially under air. That's the easiest way to do it, I find. You have much more control, and then they don't kind of clog up your cannula prematurely because you have two separate. So that's my preference, but whatever works.
But you do there's like the thin part and the thick part. Do you have any preference which one first, or it doesn't matter?
I put the thick part first, and then the
thick part first.
Yeah.
All right. Thank you.
I want to thank you very much. So, Ahmed, what do you think? Who won?
Well, that was a tie. I think everybody won, and everybody got so much to learn out of those cases. Very interesting. All cases
We
were
all won.
awesome. So
Yes.
we all
definitely
won.
all won. Lots of learning.
What do you think, Olivia? Olivia?
Great cases. We have discussed a lot of interesting tips. Salam, you did very good tips about how to make the direct interchange. Thank you for sharing that. I'm going to apply it for next case when using perfluoro. Thank you.
Thank you.
I would like to congratulate Olivia not only for the case, but also for the International Day of the Women that is today.
Oh
Congratulations,
yes,
Olivia.
congratulations,
You.
Olivia.
Thank you, guys. It's my pleasure to be between all you with all the great presentations you have. But thank you. I feel honored.
And I just want to finish, but before, I want to thank Panophthalmologica for accepting us to participate. And every one of you, you were great. And thanks also Ahmed, Marcelo, everybody else, Roger Rocha. But we have a great event tomorrow. So this is part of the great event Panophthalmologica. Before we close, and actually I would like you to close because you are presential in that big event in India, in Delhi, right now. Could you just close the session? But before, tell us what is it's gonna be tomorrow. What's gonna happen? How many people you expect in the presential event? And what do you make of these all these years of Panophthalmologica?
I think every way of putting it across is that it's going to be a hybrid meeting, and every physical meeting has its own advantage, and an online meeting has its own advantage. And the advantage that we get in Retinawesome is that by spending 1 hour or 2 hours, we learn so much because every case has one tip or one technique that we don't use, and we can use it in our practice and make our surgery better. Just like Dr. Olivia told us, tomorrow is going to be a physical meeting of around 100 surgeons coming across and from India, and we're going to be having something similar. So learning from each other's complications and surgeries to make ourselves better. And it's always been a pleasure to learn from all the colleagues, Dr. Juka, Dr. Olivia, Dr. Marcelo, Professor Lam, Dr. Habib, amazing case, and Professor Salam, obviously, less is more. So in Retina, that's what we learned. Less is always better. The lesser we do.
Thanks, Wahab. And don't forget to send us the link so that we could participate. And actually, it's going to start in a few hours because you are 8 hours and a half ahead of us.
Yes, I will surely send it. Thank you. And see everybody soon, and be safe, and happy Women's Day. National Women's Day, yes.
Happy Women's Day.
And
bye-bye.
Ramadan
Thank you,
Mubarak.
guys.
Thank
Oh,
you
thank you
very
so
much.
Thank you.
Thank
Bye-bye.
you. Thank you all.
Take care. Thank you.
Nice
Thank
case.
you.
Thank you.
Have a great day.
Congratulations. Excellent job.
Well done.